All right, welcome back, Focus Learners. In today's explainer, we are unpacking one of the most common and, let's be real, anxiety-inducing clinical mysteries in endocrinology, the solitary thyroid nodule. Relying on the gold standard evidence from Harrison's Principles of Internal Medicine, we're going to break down exactly how to evaluate, diagnose, and manage these nodules globally. We've got a ton of fascinating ground to cover, so let's jump right in.
So picture this, you're examining a patient and your fingers brush against a distinct solitary lump right at the base of their neck. What is your very first clinical move? It's a super high-stakes scenario, right? Because a misstep here can lead to unnecessary surgeries or, even worse, missed cancers. And as you'll see, the answer to this question might actually defy your initial instincts.
Okay, let's dive into this. Here is our cognitive roadmap for today. 1. The solitary nodule landscape. 2. Identifying clinical red flags. 3. Stepwise diagnostic investigation. 4. Decoding the Bethesda system. 5. Profiling thyroid malignancies. And finally, 6. Management and special scenarios.
Starting off with Section 1, the solitary nodule landscape, prevalence versus risk.
The numbers here are actually staggering. While you might only be able to physically palpate a thyroid nodule in about 4 to 7% of the adult population, if you were to take a high-resolution ultrasound to the necks of randomly screened individuals, you'd detect nodules in up to an astonishing 67% of them. Literally, more than half the population is walking around with at least one thyroid nodule.
But here's where we apply our rule-out-the-worst clinical hook. Despite how incredibly common these things are, only about 5 to 10% of solitary thyroid nodules actually harbor a malignancy. So our entire clinical algorithm is essentially just this massive filtering process. We're on a hunt for that dangerous 5 to 10% needle in a giant haystack of benign nodules.
Moving right along to Section 2, identifying clinical red flags, the bedside interrogation.
That careful examination of the neck, combined with a razor-sharp clinical history, is your first line of defense. When you're taking the history, Harrison's tells us to listen really closely for age and sex. Males and those at extremes of age, meaning under 20 or over 70, carry a much higher baseline risk. You also want to ask about rapid nodule growth, any family history of syndromes like MEN2, and crucially, any prior radiation exposure to the head or neck. That last one is a massive historical red flag.
Now, during the physical exam itself, if the nodule is hard, irregular, or feels fixed to the surrounding tissues, you need to be on high alert. Other massive red flags include palpable cervical lymph nodes, a newly hoarse voice which suggests vocal cord paralysis, a nodule larger than 4 centimeters, or signs of tracheal deviation. The rule here is simple but incredibly strict. The presence of even one of these examination red flags mandates urgent cytological evaluation. No exceptions.
Which brings us to Section 3, stepwise diagnostic investigation, gathering evidence.
Okay, this is your core algorithm. Step 1 is always a serum TSH. Why? Well, because if the TSH is suppressed, it strongly suggests you have a hyperfunctioning or hot nodule. And here's the good news. Hot nodules are rarely malignant. In that case, you'd follow up with a radionuclear scan. But if the TSH is normal or elevated, that raises our concern and pushes us directly to Step 2, the thyroid ultrasound. That ultrasound then helps us decide if we need to proceed to Step 3, which is fine needle aspiration cytology, or FNAC.
And that Step 2 ultrasound doesn't just measure size, it's looking at the nodule's personality. Is it solid or cystic? Does it have microcalcifications? What about irregular margins? By using structured risk stratification systems like ACR-TRADS, the ultrasound tells us exactly which nodules are suspicious enough to warrant that gold standard test, FNAC, where we actually pull out and look at the cells themselves.
Next up, Section 4, decoding the Bethesda system, interpreting the cytology.
Now, what's really interesting about this slide is how beautifully the Bethesda system correlates the cytology directly with clinical action. It ranks results from Category I all the way to VI. Category 2 is benign, with a tiny 2 to 4% risk of malignancy, so for those we just observe. But as you move down to Category 5, suspicious, the risk jumps to 50 to 75%. And at Category 6, malignant, well, it's near certain. Notice how the recommended management strictly scales with that risk, from simple clinical follow-up at the top to repeating the FNAC or doing molecular testing in the middle, all the way down to definitive near-total thyroidectomy at the bottom.
All right, let's hit Section 5, profiling thyroid malignancies, knowing the enemy.
Thankfully, most of what we find are benign follicular adenomas, which are basically just encapsulated growths of normal cells, or colloid cysts. Colloid cysts classically show these distinct comet tail artifacts on ultrasound. But when the pathology report reads carcinoma, we have to distinguish between malignant follicular carcinomas, which uniquely tend to spread hematogenously right through the bloodstream, and 3 other main types.
The first of those is papillary carcinoma. Honestly, if a patient has to hear the word cancer, this is the one they want. It accounts for a massive 80% of all thyroid cancers. Because it's highly differentiated, meaning the cells still behave kind of like normal thyroid cells, it carries a truly excellent prognosis when we catch it early and remove it.
Next up is medullary carcinoma. Now, this one is tricky because it arises from the C cells, not the follicular cells, and it's heavily associated with those familial MEN2 syndromes we mentioned earlier. The absolutely vital clinical pearl here is that you must screen for serum calcitonin, which is the hormone these specific cells produce, before attempting any surgery. It completely changes your entire management strategy.
And finally, we have the really grim reality of anaplastic carcinoma. This is an undifferentiated tumor. It's the most aggressive variant, often presenting as this rapidly expanding, rock-hard neck mass, usually in an older patient. Tragically, it carries the worst prognosis by far. We're talking about a median survival of only 3 to 6 months. So early palliative care involvement here is absolutely essential.
And that brings us to our final section, management and special scenarios. Closing the case.
The pathways here are incredibly well defined. Surgery is reserved for our high-risk crowd. Bethesda Category 5 or 6, any nodule larger than 4 centimeters regardless of cytology, or if the patient is suffering from compressive symptoms like having difficulty swallowing. But remember, 90 to 95% of all nodules are totally benign. For them, the pathway is simply surveillance, a repeat ultrasound at 6 to 18 months. And if they do end up having surgery for a differentiated cancer, we monitor them postoperatively using annual ultrasounds and serum thyroglobulin, which acts as a highly sensitive tumor marker for any recurrence.
So the crucial point here is how our practices have evolved. Historically, doctors would routinely prescribe levothyroxine to suppress TSH and try to shrink those benign nodules. But modern evidence-based medicine has completely changed its tune. Levothyroxine suppression is no longer routinely recommended globally, mostly because the risks to the heart and bones far outweigh the benefits. Nowadays, it's generally reserved only for specific iodine-deficient regions. Now, real-world medicine always throws us curveballs, right? So let's quickly touch on 3 special scenarios. First, pregnancy. TSH, ultrasounds, and FNAC are totally safe. Radioiodine, however, is strictly forbidden. If surgery is absolutely unavoidable, the second trimester is your safest window. Second, pediatrics. Listen to this. Children have a much higher baseline malignancy risk for a nodule. We're talking about 20 to 26%, so you have to be much more aggressive in evaluating them. Finally, incidentalomas. These are nodules found accidentally on a scan looking for something else. If a nodule lights up on a PET scan, it carries a massive 30 to 50% risk of malignancy and needs an urgent FNA.
Before we wrap up, I really want to bust a very common medical myth. If you do a radionuclide scan and see a cold nodule, meaning it's not taking up iodine, many people panic thinking cold equals cancer. That is false. A cold nodule does not confirm malignancy. In fact, only about 15% of cold nodules are actually malignant. What it actually means is that the nodule is non-functioning. And that simply mandates that you must do an FNA to see what's actually going on inside. FNA is always your ultimate arbiter.
And that brings us right to the cutting edge. We're already seeing molecular markers like the BRAF V600E mutation being used to predict just how aggressively a thyroid cancer might behave, which helps us tailor the exact extent of our surgeries. So I'm going to leave you with this final thought. With the rapid advancement in genetic profiling, how will molecular markers completely rewrite this entire diagnostic algorithm in the next 5 years? Could the needle biopsy even become a thing of the past? Keep learning, keep questioning, and thank you so much for joining me on this explainer.